Thank you for joining us tonight.
Thank you all so much for having me. Um, I am dog sitting right now, so I apologize if you guys hear some barking. I'm going to say that in advance. But today I'll be discussing hybrid repair of a proximal celiac artery aneurysm, and I have no disclosures. Celiac artery aneurysms account for 5% of, or less than 5% of visceral artery aneurysms, and 0.1% of all aneurysms total. Current SVS guidelines recommend elective surgical intervention for lesions greater than 2 centimeters in size, and optimal treatment goals are similar to other aneurysms, which is eliminating rupture risk while maintaining visceral perfusion. So proximal celiac artery aneurysms are often related to dissection and they originate at the aorta, which are particularly challenging to manage. Optimal repair requires revascularization of the hepatic artery and exclusion of the aneurysm. However, direct exposure can be difficult, and oversewing the aneurysm is often difficult due to poor tissue quality and the underlying etiology. Definitive repair has therefore traditionally required paravisceral aorta replacement, um, combined with celiac artery bypass, which can be associated with substantial morbidity. So, to avoid this, we developed a novel hybrid approach to the management of these complex proximal celiac artery aneurysms that helps address these technical limitations. So for the case, this was a 71-year-old gentleman. He was a former smoker who was referred to the vascular surgery clinic for an incidentally found 3 centimeter proximal celiac artery aneurysm due to a prior dissection. He was asymptomatic with no history of back or abdominal pain. Given the proximal nature of his celiac aneurysm, we planned a hybrid approach for repair. The first stage consisted of an open retrograde hepatic artery bypass with proximal celiac artery branch vessel ligation. The second stage involved exclusion of the proximal celiac artery aneurysm with an aortic endograft. In this case, it was a three-vessel Cook alpha physician-modified endograft. So the first stage, like I said, involved exposure of the celiac axis, kind of pictured here, with ligation of the celiac artery aneurysm and its associated branch vessels. These included the proximal hepatic artery, the left gastric artery, as well as the splenic artery and phrenic artery. The infrarenal aorta was then exposed, and a retropancreatic tunnel was created, and a partially occluding clamp was placed on the infrarenal aorta, and an end-side retrograde aorta hepatic artery bypass was then fashioned, in this case with Dacron. So after creation of this bypass and ligation of the branch vessels, endovascular exclusion of the proximal celiac artery aneurysm was performed. And here we performed a three-vessel Cook alpha PMEG with stenting of the SMA and bilateral renal arteries using VBX stents. So the patient's hospital course was mostly unremarkable. He was extubated on postoperative day 2. He was downgraded to the floor on postoperative day 3. Started on clears on postop day 5. Quickly advanced to a regular diet, and then was discharged home on postop day 7. What's interesting about this case is his follow-up was complicated first by diverticular GI bleed, requiring cessation of aspirin and Plavix, for which he was discharged on. And at 1 month, CTA revealed a celiac artery aneurysm enlargement requiring coil embolization of a proximal SMA branch. And pictured here is that coil embolization that was performed by our interventional radiology colleagues. 1 year follow-up, the patient had no endoleak with PSVs less than 200. And overall, the patient was asymptomatic and resumed on his aspirin and Plavix. So we've actually compiled a small case series on 4 patients with this type of repair. All patients were male with a mean age of 67 years with an average BMI of 31. And most common comorbidities included hypertension and previous smoking. Indications for repair included aneurysm, so 75% of the time, as well as aneurysm in dissection, which was this patient that I just presented. 1 patient presented with celiac and bilateral renal artery aneurysms, and the average proximal celiac artery aneurysm size was 2.7 centimeters. Most of these cases were actually performed concomitantly, with 1 case being a staged procedure. So first, a couple days later, followed by the endo portion. The average operative duration in total was about 320 minutes, and the most common conduits used was Dacron, followed by PTFE. Um, The average number of fenestrations or stents for the PMEG, similar to what was used in this case, was 3.5, with vessels stented including the SMA, the right renal, and left renal, with one case including superior and inferior left renal arteries. So overall, out of these four patients that we have kind of looked back at over the last couple of years, proximal celiac artery aneurysm exclusion was 100%, with an average SAC regression of 1.5 centimeters over 186 days. Total length of stay was on average 11 days, and there were no perioperative deaths. Complications occurred in two patients, one which was this delayed type 2 endoleak that we kind of discussed earlier, and the other with a postoperative pneumonia. One patient died within 1 year postoperatively from an unknown cause, and then all grafts remained patent at 1 year follow-up with an average follow-up of 463 days. So, in conclusion, open retrograde hepatic bypass with branch vessel ligation in concert with endovascular aortic exclusion and visceral stenting appears to be a safe and effective treatment for proximal celiac artery aneurysms, and it really avoids open aortic reconstruction and the morbidity that it's associated with. In this small series and case report, all repairs achieved durable exclusion with graft patency at follow-up. And this novel approach addresses a rare but formidable problem for which current guidelines provide little direction and also represents our preferred strategy for managing this complex presentation. Thank you all very much.
Excellent presentation, Walker. Thank you for sharing that case and your case series with what is obviously a very uncommon pathology. And as you point out, the location, depending on the visceral artery aneurysm, but the celiac artery aneurysms, to repair them in a totally open manner is technically not straightforward whatsoever, given the need to likely reconstruct the aorta and do supraceliac clamping and effectively a thoracoabdominal repair. So kudos to your team for coming up with a very creative hybrid solution. I think my main question, and probably could be answered better if I could appreciate the imaging a little bit better, but did y'all consider instead of doing the hybrid approach where you did the hepatic bypass, but rather just doing instead of the 3 vessels, doing 4 vessels, and the 4th vessel to your celiac artery, just extending that bridge and stent all the way out into the hepatic artery, thereby excluding the aneurysm fully. And sure, you'll shut down your splenic antegrade splenic flow, but typically the spleen will survive that ordeal with all the short gastrics and collateral flow to the spleen. So I think that's my main question to prompt some discussion. There's probably a million different ways to skin this particular cat.
Yeah, I think that's a great question and something that was, in reviewing the literature for this, it's kind of sparse for, proximal celiac artery aneurysms, but they do mention, just stenting through the aneurysm itself to kind of exclude it. At least in some of the series that I was able to find, it seems like they had a higher incidence of endoleak and as well as aneurysm filling. And so, I can't really speak on behalf of our team, but the reason that they have elected to kind of go forward with this open and hybrid repair, so I guess open and then endovascular, is that, hopefully it will prevent this kind of backfilling and endoleaks to prevent this. Now, obviously, in this case, there was a type 2 endoleak that was promptly recognized and treated. But in the other 3 cases, that was not necessarily the case. So.
I think it's a great point that Dr. Arnatakis raises, right? Because maybe there's a patient that can't get the laparotomy for some reason, whether it be comorbidity related or a hostile abdomen, and it maybe, if that's an extra tool in the toolbox to consider. If some total endovascular solution, maybe you have to a priori do advanced embolization of the splenic artery. Somehow, if you have a landing zone in the hepatic, so it's always a series of compromises. But it was a creative solution to come up with that. This is actually the work of Tom Huber and Zain Shahid at our center have done these 4 cases to date, and they were incredibly rare. And obviously, so far, so good, at least with the short-term outcomes for the patients treated thus far. But it's just another way to sort of use those techniques that we've all learned in different ways, and then to sort of come up with a creative solution for what is a rare but difficult problem.
I have a patient in my practice I've been following for years now that has a very distal hepatic artery aneurysm, and I've brainstormed a number of different ways to tackle this from an endo standpoint because I think it's so far distal. There's really not a good open solution, and
Right.
fortunately, he's just on the threshold for size criteria, and I am dragging my feet immensely having to do anything. Has not grown over the last 3 years, so I just have him in a surveillance mode. But I've spoken to a number of sort of interventional radiologists and others about this type of pathology, and at least the particular case that I'm describing, they not encourage me, but they say I could just embolize his hepatic artery with impunity, kind of thing.
Yeah, I guess if their portal vein still gives them a lot of oxygen to that liver, theoretically it should be okay, but it always gives you
Right.
pause
Correct.
because it's not something we normally do for our patients.
Yeah.
Not sure if there's any QA questions,
Um,
Dr. August.
One just appeared. Dr. Incolo in Tampa. Interesting approach. Great job. Would you consider a hepatorenal bypass instead of the aortorenal bypass? Very, very fair question.
Yeah, I think so. Yeah.
I think the one caveat on that I'll step in and answer for you, Walker, perhaps, is given the hybrid approach. Right now the aorta renal bypass, your hepatic, or sorry, the aorta hepatic bypass, everything is predicated off your aorta. Whereas if you did a hepatorenal, that bypass is living off a stented renal artery, and God forbid you have a renal branch occlusion off your fenestrated device, which does happen, and now your hepatic bypass goes down too. So I think
I
that.
think I think it's a great question. I think partly the decision making was the ligation step that occurs with effectively the branch, right? Is the with the hepatorenal bypass and cocarizing the duodenum, you could still do that and go back and find your celiac axis and exclude those branches that are back bleeding to the aneurysm or resect it and oversew it as needed. But I think that because that exposure was already occurring to deal with the celiac aneurysm to defunctionalize it, and it was pretty easy or straightforward to bring it from the aorta. But it's a good thought. There's other sort of options here. I think that all of those options are reasonable options, and there might be scenarios where maybe the infrarenal aorta is diseased, heavily calcified, and so I think our colleague from Tampa brings up a great point. Being familiar with all of these other sort of techniques for revascularization, you kind of have to put your thinking cap on and come up with creative solutions for these really rare problems. All right, just if there aren't any other questions, I think we can go to our fourth and final presentation.